thank you to Alison and her team for asking me to chair this session. It's a great privilege. And thank you all for coming today, because everyone in this room will be able to leave the room with more information and able to share that with others. So the speakers in my session, which is about treatment and treatment-related issues, I think have a really hard job ahead of them to be able to impart such insight and strength as we've just heard from the previous session. I'm almost speechless, and that's really unusual, but unbelievable messages that we've just heard. I think what we really heard a lot about was strength and a plan to live well, with or without cancer. I think the discussion about hope, openness and sharing allows everyone to build hope. And we as clinicians have a huge responsibility not only to give you information to allow you to do that, but also to be part of that journey with you. So I would like to introduce the first speaker for my session, and I think every one of the speakers in my session now have to be able to give you as much information as possible, so when you leave this room, you're better prepared than you were when you came into it. So I have a really impressive list of speakers to introduce, and I think you're going to really receive some not only important messages, but often it's people who've worked in this area for a long time, who have seen a lot, really do understand a lot about what patients are going through, and I have no doubt at all that that will become apparent. So first of all, I'm going to introduce Professor Eric Poujade-Lorraine. He is head of the Women's Cancers and Clinical Research Department at the Hospital Hotel Dieu in Paris. He's founder of the French Gyneco Trials Group, which means that that is one of the international trials group in the world that contribute to the way we design trials, particularly in ovarian, but also other gynecologic cancers. And he's been past chair of the International Gynecologic Cancer Group, which met here over the last 2 days, and have an extraordinary responsibility in making sure that we design trials for women that are actually going to lead to positive outcomes. So, Eric, you're going to talk to us about treatment.
Thank you, Claire. I'm very impressed to be there among you. All this big audience of patients and the people supporting patient. So it's a big challenge to speak about relapse in ovarian cancer. First, well, how to detect a relapse in ovarian cancer. We know that the best biomarker you can see in the blood is the CA-125, and you know we have criteria suggesting there is a relapse. It's twice the upper limit of normal. Of course, you may have a relapse if the level are a little under this limit, but there are many other causes for increasing CA-125 during the course of the follow-up. And it's not always a recurrence. But I know that for patients during follow-up, any small increase of CA-125 is dreadful. And how to make the diagnosis of a relapse, usually we use a CT scan or a PET scan, and you can find like that some spot suggesting relapse. So relapse in ovarian cancer, and I think in most other cancer, is the most distressing time during the evolution of a cancer. Well, this first relapse is something which is very depressing, and you can see there that when you ask to the patient with ovarian cancer, well, I'm hoping for a complete healing without any further complication. Well, 2/3 of the patients, when they are diagnosed, expect to be cured, and it falls to half of the patients when they first relapse. And I would like to give a message of hope, me too. If I can. It's a video from French TV of it is a patient speaking about her disease, and I will try to. It is in French, so I have to translate, and a little bit, but I don't know if I. Yes, here we are.
Michel a connu 10 récidives et autant de traitements différents.
So the first point is that this patient had 10 relapses of ovarian cancer.
En septembre, son médecin lui a proposé une chimiothérapie accompagnée d'un traitement inédit. J'ai tout de suite dit oui.
So I proposed to this patient, which was one of my patients, a clinical trial. And this patient said immediately, yes, I would like to go into this trial.
Sur le moment, quand j'ai eu ma chimio très lourde, j'ai regretté.
So to include this patient into the trial, I had to propose her. To be treated with 4 cycles at least of platinum, but she had hypersensitivity to carboplatin, which is the best drug in ovarian cancer. So I had to propose her cisplatinum, which is much more toxic. And she said, well, that when she was under this treatment, which was much more toxic, she regretted to have said yes. So she was, of course, as many patients during the treatment of their relapse, full of doubt.
En disant pourquoi je souffre autant pour vouloir faire un nouveau traitement. Et maintenant, au bout de 6 mois, je ne regrette plus. Parce que j'ai l'espoir, comme j'ai la chance d'avoir des bons résultats, j'ai l'espoir de guérir. Bon, on verra.
So she said that, at the beginning, she was suffering from this toxic chemotherapy, and she regrets, of course. But now, it was 6 months ago, she had 6 months complete remission. She did not regret anymore, and she was hoping to cure. So that's fantastic, after 10 relapse, to have still the energy to think that you are going to cure. And I must say that it was 6 months ago, and so now she's still in complete remission, and she has it's already 1 year in complete remission. We'll see. Perhaps she will be right. I hope. So then. Because as you see, I did it. Not so easy. Huh? Because it's often distressing to see this disease with several relapses. So that's why we call ovarian cancer as a chronic disease with multiple relapse. So when we try to treat patients with ovarian cancer, what are the goals? Well, the goals depend of when the relapse has occurred. You have early relapse, the patient relapse very early after the last platinum treatment, or later. So that's called the resistant relapse, and later, and it's the platinum-sensitive relapse. Of course, when it's a platinum-sensitive relapse, that means the treatment, we know that the treatment has a very high chance to be active. We try to still be in kind of curative, or at least to prolong survival as much. And when the treatment is less active, of course, the quality of life is even more important. So what we do, well, first, the most important thing is to treat symptoms. then to propose to patient to enter a trial, because we have many trials, and we know that it is an opportunity for patients to have new treatment, new active treatment. And we have always to consider surgery. And we have now from the German, and Jacobus Pfister is the German representative here of the German group, we have a score which can say if the patient have a 75% chance to have a complete resection of her cancer. So with this score, we can predict the efficacy of surgery, but we don't know yet if to remove all the cancer at relapse is able to increase the cure rate. So that's why there is a randomized trial between surgery and no surgery in patients in relapse with ovarian cancer. Well, the other weapon we've got, of course, is chemotherapy, and you see all the list of the drugs which are active in ovarian cancer, suggesting that you can combine them in different way. So that's a large armamentarium of possibilities in the treatment of ovarian cancer. But now the question we can ask to you and to patients is how should we improve the treatment of ovarian cancer? And this is a survey of more than 1,000 patients with ovarian cancer from 8 European countries, done by the NOGO, the German people. And you see that one of the things the patient ask is you should develop a treatment without alopecia. And it's exactly what we tried in a very large trial in a patient in relapse, where the standard is, again, carboplatin and Taxol, which unfortunately make the hair loose. And there we substituted paclitaxel with another drug, which gives much less hair loss. And indeed, it appears that you don't need to be more toxic to be more active, because this combination was a bit more active, and but much less toxic. Look at the rate of alopecia, that's the standard, with carboplatin and Taxol, or paclitaxel, and with the new carboplatin PLD, it's a Calyx or Doxil, and you see the rate of alopecia is very low rate of allergy to carboplatin, and neuropathy tingling in the hands or in the feet is much less. And you can see that at the 15 months, more than 9 months after the end of the therapy, you have much less neurotoxicity with this combination. So we tried to have combinations which are less toxic for the patients. So that's, I think, one progress in our field. Well, the second thing the patient would like is to counter fatigue and more effective therapy. Indeed, when we ask to the patient with ovarian cancer, because we didn't before ask really to the patients, what are their symptoms? You can see that here in this light green, these are abdominal symptoms. But the most frequent symptoms are fatigue, and we understand why the patient said we would like to have less fatigue, and trouble of sleeping. So we should have more active treatment. And well, chemotherapy, I think we are on the top of the possibilities for chemotherapy. So now it's the era of targeted therapy, the area of CLAIR. And one of the major ideas has that you see this tumor, that's the normal blood vessel, and all these new vessels which are bringing nutrient and oxygen to the tumor, which allow the tumor to grow. Well, if we could have a treatment like Bevacizumab, Avastin, which cut this vessel, that might help in the treatment of ovarian cancer. And indeed, Bevacizumab, this monoclonal antibody, was much more active than all the targeted therapy which was studied a few years ago in the GOG, US GOG. And 4 trials have shown that bevacizumab indeed brings a progress in the treatment of ovarian cancer. And I will show this trial. Mainly, you are going to see you are a patient with early relapse treated with chemotherapy or chemotherapy plus Avastin. And this trial has shown a very big benefit for the patient in terms of decrease in tumor size and control of the disease. But what was very important, and I must thank the Australian people to have helped me to look at the quality of life of the patient in this trial. And you have a very significant improvement in gastrointestinal symptoms. It was the first time that in a trial you add a drug, but you have improvement of symptoms. You know, usually when you add a drug, the patient feels worse because you have more toxicity. So here you see twice as much, a very significant improvement in gastrointestinal symptoms. And all along the treatment, you have an improvement in the feeling of the patient with gastrointestinal symptoms. This is progress indeed. Well, the next progress, which is ongoing, is dependent of the knowledge of the biology of ovarian cancer. I think Jan has shown you the new ideas. I remind you that in the most typical ovarian cancer type, which is high grade, you have a mutation in a molecule which is the genome keeper. So if the genome keeper is non-functional, you have all these mutations which are not, there is not an inspector, there is no more an inspector to say, oh, well, we should repair this mutation. So, and in addition, in many ovarian cancer, so you have mutation, but also the team which repair the mutation, the DNA, is deficient. That's the team, you know, the DNA there. And you see the guy trying to repair, but he's not very well there. So at the end, the chromosome, there is a very big instability in the chromosome. And you see, this is the chromosome of, in the tumor of ovarian cancer. You should have 2 chromosomes. Look here, you have 5, and all these colors. So it's a very different from the normal chromosome in the tumor. But this is also the Achilles heel of ovarian cancer, you know, because it's not very tidy, it's not clean, it's a kind of chaos, but still the ovarian cancer cells survive. Why it survives? Because usually the teams which repair DNA go 2 by 2. So here you have, if you have a deficient in BRCA gene, that means that you have one team which is deficient, but to repair DNA, you have another team, which is the PARP. So if you give a drug which block PARP, you have nobody to repair, so the cow is increased and the cells die. So that's the anti-PARP. So the anti-PARP, and there is a very famous trial in ovarian cancer in relapse, comparing after chemotherapy olaparib, which is an anti-PARP, and placebo. And in patients with BRCA, which are BRCA mutated, you hereditary mutation. So one team of a DNA repair is not functional, and you add an anti-PARP, you see these fantastic results 82% reduction in risk of disease progression. So that's a very big advance in the treatment of ovarian cancer. And the next, so we are working a lot to optimize this new treatment. A lot of trials are ongoing. And the next step, because the future will be brilliant in the treatment of ovarian cancer, will be to immunotherapy, to reinforce the immune defense of the patient with ovarian cancer, because now we have tools which are able to do that. Look at all these immune defense cells attacking the cancer cells, and you see that if you have good immune defense, you have a better chance to be cured by the treatment. So the next and final point is that the patient complains, and you have already heard that, and you know that they have not enough information. How best to deliver information when the treatment is with a doctor? It's important to have a trusted person or an additional physician. In France, we have an additional nurse, and to explain very well the therapy schedule. There is a big need for information for patients, and particularly about clinical trial. You see that in this survey, 1 out of 4 of the patients have already been included in clinical trial, which is enormous. You know, usually it's less than 10%. So that means ovarian cancer patients want to be included in clinical trial, and 68% would be interested in having a second opinion. So greedy of information about the disease. But when we ask, do you know a place where patients can be informed themselves whether they are receiving the best possible treatment, 91% of the patients say, no, I don't know the place. So we tried in France a website since 10 years. It's quite popular with 1 million hits, but not a day, but a year, which is already not bad. We have also a site for rare tumor of ovarian, and you see that's the front page, and you have of the front page is for the patient. And the patient can find where are the expert centers in France for ovarian cancer. And I would like to end this speech with another message of hope. These are the figures in France, and I think it should be the same, I guess, in many countries, including Australia. This is the incidence, the frequency of ovarian cancer, and you see that it's with time, it is decreasing, because mainly the patients who are getting ovarian cancer today are the first women who use the birth control pills, which decrease up to 50% the incidence of ovarian cancer. But you can see also that the mortality in ovarian cancer is decreasing steeply. And in the last 25 years, you see that that's the figures of 6, and now we are 4. 1/3 of the way has been done. Well, we still have a lot of work, but anyway. And it is, you see there, well, perhaps not all that indeed the decrease of mortality every year is superior to the decrease of incidence, suggesting that the therapeutics tools and the way to treat patients is better and better with time. Thank you very much for your attention.
So I think we have a few moments for questions. I would just like to thank Eric for really giving us an understanding of where the field of treatment sits at the moment, and we're going to move on from this and talk about trials and research. So I just wondered if anyone had a question at the moment for Eric concerning perhaps where treatment currently stands today. Up the back?
Michael.
Wait a minute. Professor Quinn, you're just going to have to wait. Could we please take the question? Go ahead.
Thank you. I am an ovarian cancer survivor of 5 years next month, and I feel very blessed to have got this far. My question is, I had abdominal chemotherapy, and I would like to know why there are so many different treatments. And I know there's different stages and so forth, but yeah, why abdominal and some people don't have it?
So you had intraperitoneal chemotherapy?
Yes.
So that is an option, which is a good option. The point for intraperitoneal chemotherapy today is we feel that we didn't yet obtain the best treatment in terms of balance between toxicity and activity. So I don't know how you tolerate this treatment, but what we feel is that many patients to whom we give this treatment do not tolerate very well.
Yeah, I understand that because it was very, very tough, and apparently there's 1 in 5 people drop out of the actual treatment.
Yes, even more. So that's why there is some reluctance in some teams to use that, or at least there are many trials ongoing to try to find what is the best combination for this treatment, which is very active indeed. You are the evidence of that. And I must say also that I agree with what Pat said. I don't like the name survivors. I think that I agree that I don't know if it's your feeling, but a portion of the patients indeed live better when they are cured, of course, after than before. So it's much better than survivor.
Yeah. I prefer survivor to remission.
Oh, it's for sure.